Hello everyone and welcome back to the final lecture in the cardiovascular series, Cardiovascular Diseases. By the end of today's lecture, we should understand a number of the risk factors for the development of cardiovascular disease in current society. We'll also take a closer look at the molecular mechanisms for diseases like atherosclerosis and heart disease, and then look at the effects that hypertension and hypotension have on our society. Let's start by taking a look at all the different types of cardiovascular diseases. We'll first look at coronary heart disease, that is, disease of the arteries in the heart, the coronary arteries. And cerebrovascular disease, that's disease of the vasculature in the brain. Peripheral artery disease, that's disease of the peripheral arteries all through the body. Rheumatic heart disease, that's when you get an infection in your heart. Normally a bacterial infection can lead to rheumatic heart disease. There's also congenital heart disease, which is an inherited form of disease where the heart doesn't develop properly. And lastly, deep vein thrombosis. And this is the type of clot-forming activity that can happen in your lower extremities that leads to things like pulmonary embolism. We can take a look at the effects of heart disease on the global population by looking at this table, which shows cardiovascular disease is the leading cause of deaths worldwide. We examine the graph in the middle and start with the orange bars. You see cardiovascular diseases far outpaces all the other diseases on the planet in leading to death, including cancer, chronic respiratory disease, and diabetes. And so it's obviously a serious problem that we need to get under control. In fact, if you look at these sort of facts in the middle here, you see that 1 in 3 Canadians will die of cardiovascular diseases, and 1 in 5 Canadians will succumb to heart failure. Those are astounding numbers when you think of the size of the population and the number of people that are getting this disease. When looking at the effect of a disease on a population, we can look to the risk factors as important determinants of whether that disease should be growing or decreasing in a population. And for cardiovascular disease, we must also appreciate there are uncontrollable factors and controllable factors that are risk factors for this disease. For example, uncontrollable factors might be the genetic background, the genes you inherit from your parents. You have no control over what genes you receive from mom and dad. But modifiable lifestyle factors might be the amount that you exercise or the amount that you eat. And so we'll just take a look on this first page at 2 important risk factors, and that is blood lipids and diabetes mellitus. In the case of blood lipids, there are 2 types of lipids we think about when we're measuring lipids in the bloodstream. The first type is the bad lipid called LDL, or low-density lipoprotein, and it's associated with another apoprotein called apoprotein B. When these levels are high in the bloodstream, it means you have a very high risk of cardiovascular disease because these are large, floppy bags of lipids that can deposit them at various points through the cardiovascular system. So very dangerous when LDL is high. However, in contrast, the good lipid is HDL, high-density lipoproteins. And so if you have large amounts of high-density lipoproteins, those lipoproteins are associated with apolipoprotein A1, and they're tightly packed and very difficult to get distributed into the blood vessel walls. So the ratio of HDL versus LDL is a very important determinant of how healthy your lipids are in your circulation. Secondly, diabetes mellitus can lead to very serious metabolic disorders that contribute to the development of atherosclerosis. And so protecting yourself against obesity and resulting metabolic disorders is another very important tool we have in our toolbox to protect ourselves from cardiovascular disease. And so when we look at all the risk factors for cardiovascular disease, You can see they're broken down onto the left side and right side of this diagram. On the left side are all of the risk factors that are not controllable. These are things like sex, age, and as we discussed the last slide, a family history, the genes that you get from your mother and your father. These are all things that you have very little control over, but can still contribute to the development of disease. Fortunately, however, there are a number of controllable elements available to us to protect ourselves. For example, the choice whether or not to smoke is very important. Smoking causes damage to the endothelial lining. The smoke itself, the chemicals in the smoke can lead to endothelial cell damage and increased susceptibility of disease. Obesity, so maintaining a normal, healthy weight, is another important controllable factor that's linked to your lifestyle, a sedentary lifestyle versus an active lifestyle. Get out, exercise, be active, and that you'll reduce the chance of cardiovascular disease in your life. In addition, high blood pressure, called hypertension if left untreated, is another important risk factor. So this is why it's important not only to go to your doctor and have your blood pressure measured, but also to stay on the hypertensive medicines that they give you to reduce this chance of cardiovascular disease. In addition, your cholesterol levels, as we discussed, that LDL, if those levels get too high, there are mechanisms or drugs that you can take to actually lower those and get them back into the normal range, again, reducing susceptibility to disease. And the last thing we can do is reduce the amount of stress in our life. Through things like yoga or meditation, it's possible to reduce sympathetic drive and things that would normally elevate blood pressure and might lead to more cardiovascular damage. Now, this slide was added somewhat as a joke or a funny slide to really bring across the point that things have shifted in our society such that cardiovascular disease is not only a disease of the elderly anymore. In fact, younger and younger individuals are developing these risky lifestyles, and so by the time they become young adults, they're very susceptible to cardiovascular disease onset. And this is data that's brought to us by the Heart and Stroke Foundation of Canada, so it's meant to be taken very seriously. You need to, at the very earliest stages of your life, develop the habits and lifestyles that will allow you to have a healthy, happy cardiovascular system into your older ages. The first cardiovascular disease we'll look at closely is atherosclerosis. Try saying that 10 times fast. Now, I've been lucky enough to be the president of the Canadian Society for Atherosclerosis, Thrombosis, and Vascular Biology. And so I've seen some of the amazing work that's being done in this country and across North America to help cure this disease. What causes atherosclerosis is a buildup of fatty material that we call plaque. And this plaque is made up mainly of cholesterol, and it gets in under the inner lining of the endothelial cells and deposits itself directly into the vessel wall. And as this plaque grows in size, it can actually start to restrict the blood flow in certain areas, and that disturbed blood flow can actually lead to clotting of the blood. And if blood clots, then this clot can at some point dislodge from this lesion and then circulate and clog up some other part of the arterial system, whether it's in the lungs with a pulmonary embolism or sometimes in the brain where it causes strokes. So atherosclerosis is a very serious disease that can slow blood flow due to either this blockage from the plaques or from a clotting event that goes wrong. So to understand the progression of atherosclerosis, we must first understand what a healthy vessel looks like. Here you see in this healthy vessel, the endothelial cells are tightly joined, forming an impervious barrier to things that might want to deposit in the vessel wall, like low-density lipoprotein. But all it takes is for someone to be a chronic smoker or to have a lot of stress in their life, and this endothelial cell lining can become damaged. At that point, things like LDL and fats and cholesterol can get through that endothelial cell barrier and start to deposit themselves underneath the endothelial cells. And so this then becomes sort of the dangerous part or the risk factor part in some of these things like smoking and stress. Now, once that LDL gets under that endothelial cell layer, then we see what is called the fatty streak formation. And this is an important stage of the development in plaque. So here at the top of the screen, our LDL now is depositing its lipids into the vessel wall, and that's what this yellow color is. And these lipids, once they get into the vessel wall, the body actually senses this as damage, and it sends immune cells like macrophages there to help clean up some of the fatty lipids. And in fact, they try to do so by devouring or eating up a number of the lipids. This causes some changes in the macrophages that we'll actually see downstream when we look at other stages of plaque formation. But the other thing the macrophages are doing, in addition to trying to eat up the fat, is they're recruiting other macrophages and smooth muscle cells into the lesion. The smooth muscle cells respond to these signals from the macrophages by proliferating in the medial layer and then migrating out into the lesion, where they're going to start to put down extracellular matrix. This is to try to assist in the healing program that the macrophages have initiated. And so once these macrophages and smooth muscle cells have done their job properly, we develop what's called a stable fibrous plaque. And in a stable fibrous plaque, the lipids are still present in the vessel wall. A bunch of them have been eaten up by the macrophages. The smooth muscle cells have aided in the healing by depositing this layer of fibrous tissue that's actually structurally surrounding the lipids and stabilizing the whole plaque area. And this is to prevent it from suddenly ripping open and causing damage that would lead to clotting and downstream events. So while these macrophages are phagocytosing these lipids, they're also oxidizing them. And what this means is that they can turn into, through these oxidized lipids, they turn into a different type of cell that's called a foam cell. And in very late stage lesions, it's the foam cells that will predominate within the lesions. In addition, some of the smooth muscle cells turn into bone-forming cells, and they produce these calcified structures inside the lesions. So in addition to putting down the fibrous layer, they're also trying to lay down these calcified structures that create an interesting heterogeneous environment between the softness of the cells and the hard, crunchy bone that's being deposited. As more and more of the macrophages convert into foam cells and become these big, almost bubble-like structures within the plaque, more and more calcifications create a very heterogeneous environment that is easy to disrupt as blood is trying to flow over the lesion. And in these plaques that have such a heterogeneous shape and have lost their ability to maintain that stable structure, those now become what are known as vulnerable plaques. Those are plaques that are vulnerable to rupture, and when they do, by releasing their contents into the bloodstream, they attract platelets and other blood clotting mechanisms to begin clot forming at the site of the ruptured lesion. And it's this rupturing of the lesion and clot formation that ultimately makes this situation the most dangerous, because the more clot is produced, it can then flow downstream and begin to block other arteries, either in the same vessel system or down in other parts of the cardiovascular system. In this diagram on the top left corner, we compare a stable plaque to an unstable plaque and follow the sequence of events for the unstable condition. The stable plaque, we remember, has this beautiful, thick, fibrous cap shown in this purple color here, surrounding the lesion and really protecting it from rupture. We note this is missing in the unstable plaque, and in addition, this plaque has a very heterogeneous core with lots of calcifications, lots of empty spaces where foam cells have been, and also this heterogeneity of lipid structure makes it a very easy structure for blood to break and disrupt. And that's exactly what we see in the second slide here. Now that we've ruptured this lipid at the shoulder here, it's releasing its contents into the bloodstream, and this very quickly attracts clotting agents like platelets. The platelets rush to the site of injury, and this is normal to help protect the blood vessel from bursting. But in fact, what happens is that quite often there are so many platelets present that they not only block the blood flow and prevent the leakage, but they can actually result in the occlusion of the entire artery. And it's this occlusion that can be disrupted at any point by the blood flow, so that clot is dislodged and then travels downstream and gets lodged somewhere else in the circulation. This is the primary danger for the unstable clot or unstable lesion, leading to clotting and further problems. Now we'll take a closer look at ischemic heart disease. An ischemic heart disease is simply defined as the imbalance between the supply of oxygen and the myocardial demand, resulting in myocardial ischemia. So in other words, the heart's not getting enough nutrients and oxygen to function properly. In many cases, these ischemic events can be caused by the development of an atherosclerotic lesion in the coronary arteries. So this is very similar to the mechanisms we just went over on the last slide. And you can see as that plaque grows, it begins to hinder that flow of blood as it's trying to flow through the coronary arteries. And if this happens high enough up in the coronary arterial tree, you can see that you can affect large areas of cardiac tissue where they would become ischemic downstream of that lesion. And this principle of regional ischemia is very clearly demonstrated in the diagram on the right. So here we're going to look at what happens if you have a blockage or a lesion at point A, which occurs very high up in the coronary arterial system, right near to the aorta, versus what happens when you have a blockage at position B, which is way out in the extreme end of the coronary vasculature. As you might predict, if you block the artery at position A, you're going to lead to a large area of ischemia shown by this pale gray color that shows the large swath of tissue that's affected by blocking that single artery. This would be the most dangerous condition for an individual to have a lesion or a blockage that occurred so high in the system. By contrast, if you had a blockage at position B, down further in the circulation of the coronaries, you would see that you would only result in a small area of ischemic tissue, as marked by this dark gray circle that we see. This might not even be detected by a doctor or a patient if it were to happen in a real individual, because it's such a small area. So obviously, this would be the more desirable of the two cases, to have something blocked out in the very extreme end rather than at the entry point or the high end of the coronary circulation. So it's in this way that if you have ischemic heart disease, it can manifest itself in some very different manners depending on the geography or the location of where the blockages occur. And these manifestations can range from asymptomatic, and that might be the case we saw at position B on the last slide, where only a very small amount of tissue was affected. You can have what's called stable angina pectoris, and stable angina is when there's a blockage that's persistent, but it only affects you during exercise or exertion. So during normal heart activity, you really don't feel anything, but you might feel a pressure or pain in exercise as that ischemic tissue became more ischemic due to the nature of the exercise. You can have something called myocardial infarction, which is a complete blockage of the vessel, and that would lead to this ischemic area like we saw on the previous slide. And in many cases, the energy inside these cells controls ion channel activity. And so disruption of the ion channel activity leads to arrhythmias or abnormal electrical conduction through the heart. If you have a tissue that's ischemic for long enough, some of those cardiomyocytes may die, and as they die, they get replaced with fibrosis and other tissues that tries to prevent the heart from exploding. But what happens is that over time, heart failure develops. The heart becomes stiffer in some areas, floppier in others as it remodels, and this leads to a 3 to 5 year period of the heart condition weakening over time during heart failure. And normally, heart failure patients, 50% of them will die within the first 5 years of having this disease. The last thing that can happen is you could have sudden death occur, and this would happen in the case of severe arrhythmogenesis, like ventricular fibrillation that might be caused by this blockage, or lead to other things in terms of cardiovascular disease and cardiac rupture that would lead to sudden death. So if you were to have a heart attack acutely, an acute myocardial infarction, here are some of the tools that they would use to help diagnose whether this was actually happening. And these would be done in both the emergency room and maybe in intensive care right after they took you in through the emergency. So normally the patient would be experiencing chest pain, and this pain can radiate out into the arms, but the immediate effect would be a severe pain in the chest. What they'll do is they'll take blood samples and they'll look for myocardial enzyme elevation. And so remember, as these areas become ischemic, some of those cardiomyocytes that die actually release their content into the local milieu. And so things like creatine kinase and troponin are in high concentrations in myocardial cells, and these are released into the bloodstream following a myocardial infarction. The doctors or nurses will also likely perform an electrocardiogram. And one of the most important changes that we see in patients that have undergone an acute myocardial infarction is an elevation of the ST portion of the ECG curve. And this ST elevation is actually caused by the activation of potassium channels in high amounts, because the low energy caused by ischemia, the low amount of oxygen, doesn't produce enough ATP to maintain the closure of those channels. And so under low ATP conditions, that potassium is shipped out of those cells, and this results in this ST elevation that we see in this curve on the left. And this is obviously compared to an ST segment that stays very close to the baseline levels in normal, healthy hearts. Once doctors have confirmed that this is a myocardial infarction, then there are a number of treatments that they could provide depending on the severity and the circumstances. So under sort of mild conditions, certainly rest, increased oxygen, and pain relief is very important. And importantly, aspirin is often used in this circumstance because it also prevents excessive clotting from happening. So symptom relief and reducing platelet adhesion by these methods. In severe cases where it's clear that there's a clot that may be blocking larger parts of the coronary circulation, thrombolysis is a consideration. This is the lysis of those clots using TPA, tissue plasminogen activator, which converts plasminogen to plasmin and breaks down fibrin in pre-existing clots. So in this way, you can hopefully restore normal blood flow to the tissue that are being blocked by larger clots. Patients with long-term blockages may receive what's called primary angioplasty. This is the physical removal of the blockage, and we show some examples of this in our slides that follow. Beta blockers can sometimes be prescribed. Beta blockers are beta adrenergic receptor blockers, and because of their nature, they actually slow heart rate. They inhibit the sympathetic activation on beta receptors. They slow heart rate, and they also reduce the heart's workload, which is helpful under certain circumstances for individuals with acute myocardial infarction. And lastly, the ACE inhibitors. We remember that ACE was a component of the renin angiotensin aldosterone system. And so by preventing the production of angiotensin II, you can block some of the major effects of renin angiotensin on afterload, and thereby reduce, because it's a vasopressor or because it drives increased blood pressure normally, you can reduce blood pressure and reduce afterload, and also some of the remodeling that happens downstream of angiotensin receptor signaling. So it's a multifunctional inhibitor blocking the renin angiotensin system, preventing high afterload and preventing cardiac remodeling. And as we said, if the infarct is severe enough, over time the patient will develop what is known as heart failure. And heart failure simply represents the case where the cardiac output is inadequate to supply the body with all of its circulatory needs. It can be caused by heart disease, as we've discussed. It can be driven by severely high blood pressure over long periods of time that ultimately weakens the heart muscle and turns it into a large remodeled floppy heart. And it can also be induced by electrolyte imbalances where the heart walls remodel themselves. The treatments for heart failure can be digitalis, which increases contractility of the heart muscle and gives you stronger, more forceful contraction. Often diuretics lower the blood volume in individuals and therefore lower the afterload. So this helps reduce blood pressure and lower the afterload. And then sometimes nitroglycerin is given as a vasodilator, and this can serve local purposes in the heart. It can help vasodilate and get more blood into the regions of the heart where blockages may have been preventing flow. But it also works on the peripheral vasculature to help lower total peripheral resistance and lower blood pressure as a result. The overall goals here are to help make the heart work more efficiently and reduce the stress on the heart that might lead to further remodeling or strain. One of the treatment choices for someone that has this blockage in the heart might be angioplasty or percutaneous coronary intervention. This is simply a procedure where a wire and a balloon are inserted in through the coronary vasculature, and then they're used to try to open up the blockage that has occurred in that individual as a result of either a plaque or a clot. In this example, before the angioplasty experiment, you can see that there's a narrowing of the artery here at this point. I hope you can see where I'm showing you. The arrow is pointing to it. I'm circling that narrowing that's caused by the lesion that we're trying to clear. The idea is to extend the balloon into that area and then expand the balloon out so that it moves the vessel walls outward and then increases the size of the lumen to optimize blood flow. And hopefully you can see the blood flow has been restored and the lumen now is fully open to allow blood to flow downstream into those cardiovascular tissues. Here on the right-hand side, we see an example of this happening in cartoon form where the balloon is being opened and you can see you're sort of squishing the plaque outwards towards the vessel wall, and this is opening up the lumen and allowing more blood to flow downstream into those tissues. Here in this diagram, we see two important tools that physicians have to treat this coronary artery disease. The first is the coronary artery stent. That's what's shown on the left-hand side. Or the second is the coronary artery bypass surgery. That's shown on the right-hand side. And if we look first at the stent example on the left, you see it is essentially like the angioplasty surgery that we saw on the last slide. So you have this nice balloon that can be expanded right at the point of the lesion. But in addition to having the balloon there, you have a metal stent that acts as a scaffold that can be expanded and then hold the vessel wall in place after the balloon is removed. So in this way, you have a much stronger structural feature that's been added in a permanent fashion to the vessel to help maintain that patent open structure. And this then becomes a longer-lasting solution in many cases than angioplasty alone because of that stent feature that's left in place. One potential problem that the patients have long-term is that sometimes you get clotting around the stent, or the stent can induce injury in the vascular wall that causes repair-like events to happen that then close the lumen of the vessel back. So it's not perfect, and we're still researching better ways to reduce the injury of the vessel wall and the amount of clotting that actually happens on the stent. And we can compare the stent solution now to what we call coronary artery bypass surgery, and this is the diagram on the right. And under these circumstances, what you can see are that the blocked vessels that are sort of shown here with these arrows at various positions in the heart, those vessels can actually be bypassed by grafting veins that would carry blood from the aorta around the actual blockage and then allow perfusion downstream of those blockage sites, thus bypassing the site of occlusion and giving you improved perfusion of the extreme levels of the coronary vasculature. And so in this way, we have two very effective solutions for improving blood flow beyond these blocked vessels. And in cases where all of these different treatments that we've gone over the last few slides have not worked, and the patients have evolved into serious advanced heart failure, the one final solution that we have for these patients is a heart transplant or an artificial heart. And so in the case of the heart transplant, you can see that the patient's heart is removed and replaced with a donor heart that matches the blood and tissue types well enough to prevent that heart from being rejected in the individual. And with successful surgery, you can see that the new heart is basically transplanted right into position where the older, where the old tired heart was originally found. Often, as a way to keep patients alive before they receive a heart transplant, they will receive an artificial heart. And so this is just an example of an artificial heart that comes with its own little power pack, and essentially is a plastic heart that's functioning as a pump that keeps blood flowing through the circulation until the patient is able to receive their own heart from a donor. These are obviously not long-term solutions, but patients can live up to a year or two with some of these artificial hearts. And what's interesting is that often when you reduce the strain on their own heart with one of these artificial hearts in place, that heart actually starts to recover a bit of its actual function. And now, as we get into the last section of the slides today, we're going to talk about blood pressure regulation. And before we talk about all the things that can go wrong, let's look at what can happen even in the course of someone's normal daily blood pressure regulation. See, blood pressure normally occurs in cycles over a 24-hour period that match our diurnal rhythm. And this is because we tend to have higher sympathetic activity during periods of activity in the day, and higher levels of parasympathetic activity when we're sleeping. And so you see this normal rhythmic higher in the day, lower at night pattern in our blood pressure regulation. But then from there, you see that there's a whole host of other things that will help determine where our blood pressure sets during the day. And it's really based on activity, right? So if we're sort of sitting at home on the computer, you can see that your blood pressure's not likely to be very high. But if you're up and around and prepping dinner, maybe it's a little higher. If you're washing up for bed, maybe it's a little higher. Sometimes if you're at your doctor's, and this is particularly true for me, and you're having your blood pressure checked, your blood pressure can be very high. And this is called white coat syndrome, where you actually, in anticipation of seeing what your blood pressure is, all of your sympathetic drive increases your blood pressure to higher than normal levels. And so over the course of any given day, you can have these wide variations in your blood pressure, and this is 100% absolutely normal, and in general, not indicative of anything other than normal activity levels. There are, however, a number of sort of risk factors or extrinsic factors that can determine or ultimately lead to higher blood pressure. These are things like age, your sex. So, for example, males are more likely to have higher blood pressures than females. Your weight, so your blood pressure goes up as your weight increases. Your race, and this is true, certain races also have higher blood pressures than others. Your mood, your posture, things like socioeconomic status, which leads back to stresses and sort of effects on your lifestyle, in addition to your normal physical activity levels. All of these things can impact where your blood pressure will set and how it will evolve over the course of your lifetime. And what we're going to talk about for the remaining slides on the lecture are those alterations in blood pressure that are well outside the normal range of things we just saw on the last slide. And so, for example, we can start with hypertension or high blood pressure, sustained elevated arterial pressures of 140/90 or higher. So these, I think the key word here is sustained. We're not talking about transient elevations that go above that. We're talking about when your resting or normal blood pressure is sustained at these levels, that is considered hypertensive. So we don't worry about transient. It's the chronic elevation that provides that chronic afterload stress on the heart, continued pressure on the heart to have to forcefully squeeze harder to eject more blood, that ultimately leads to things like hypertension-induced heart failure, as we discussed in some of the last slides. You can also lead to higher pressure on brain arteries, for example, and that can lead to stroke. You can have higher pressure on an aorta where its wall is weakened, And so you can have things like aortic aneurysm. And so these are types of vascular disease that can happen. You can damage the kidney with higher than normal pressures, because remember, the kidney's very sensitive to pressures and flow because it's trying to regulate blood volumes. So you can blow out your glomeruli and those pressure sensing areas of the kidneys if the pressures are too high for too long. The opposite of hypertension is hypo, that is low blood pressure, and this is where the systolic pressure is recorded below 100 millimeters of mercury. And the reason why it's important to keep an eye on hypotension is because these individuals are fairly prone to fainting if they stand up too quickly and they can't maintain perfusion pressure of key tissues like the brain, then they will faint very easily. And so it's a good idea to keep an eye on individuals that have low pressure as it is to watch high pressures. We understand that there are two types of hypertension out there. The type that is called essential hypertension, and this accounts for around 90 to 95% of all of the cases of hypertension that we know of, yet unfortunately the true cause is not known. We can measure someone's blood pressure and say we know it's higher, but for the vast majority of patients we have no idea why that is. And it would take a lot of work and effort to try to figure that out. And so what normally happens is they're given an antihypertensive drug, their blood pressure comes back to normal, and they're able to maintain a normal lifestyle on that drug for the rest of their life. So we never even really find out what the cause of that hypertension was. But in those cases, the vast majority of cases, we call that essential hypertension. And we distinguish that from what we call secondary hypertension. These are that 5 to 10% of cases where we actually know what's happening. There are known disease processes that can either affect blood flow, or there's a known damage to a tissue that we know is involved in blood pressure regulation that can result in the release of chemicals that cause blood vessels to squeeze and increase your vasoconstrictor activity and increase mean arterial blood pressure. And some patients can also have damage to sympathetic nervous system or other blood pressure regulating areas. And if we know what the cause is, then we can have very specific treatments or attempt to very specifically treat that disease. But those are the rare cases. Most patients are just given the general antihypertensives, sometimes diuretics, sometimes calcium channel blockers, sometimes renin-angiotensin, aldosterone system inhibitors to help drive blood pressures down. And so what's one of the most important reasons to stay on top of blood pressure and try to keep it in the normal range? Well, it's really that our baroreceptors are keenly tuned to what our normal blood pressure situation is. And the best example of this is on the left-hand side. If you take a look at, this is the normal arterial pulse wave that happens with every cardiac cycle. Okay? So when you look at that pulse wave, and then you look at the baroreceptor response in terms of how that baroreceptor fires, you see that it barely fires at all for somebody with a very low blood pressure that was in the sort of 50 millimeter mercury range. You would have a very weak baroreceptor control over what was happening. So the signals that the brain got about what was happening with blood pressure would be few and far between. You see this improves around 70 millimeters of mercury, but it's still not ideal. You see a few firing as that pressure, high pressure is sensed, but again, you're missing a lot of critical information about the blood pressure during diastole and as we come off that peak curve. Now as we get into the range of normal blood pressure, this 100 to 125, you can see that we have optimal signals arriving at the cardiovascular control center. You can see the nice rapid firing early and then a tapering of signals in the 100 and the 125 range. This is the normal range where our baroreceptors are tuned. And here, what you can see is that you go up to 200 and you've lost all of that sensitivity again. And so you just basically see fire, 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 fire along the baroreceptor. Again, giving you very limited information about what happens with each cardiac cycle. So taking this information, what we know happens now is that our baroreceptors, if they go too long with high pressures being the steady state, in other words, if you went for months to years with hypertension, those baroreceptors would actually reset. And in resetting, they would learn to think that those high pressures were normal. And so, obviously, this would have an effect on their ability to feed back and control blood pressure. And the easiest way to think about it would be to say, let's say that your blood pressure was 180 millimeters of mercury. And that was, let's say, your mean pressure. That's a very high pressure. But if your body thought that was normal, then it would be sending signals to the brain in the 100 to 125 region for each cycle instead of something that looked like the 200 region. If the cardiovascular control center received the signal for the 200 region, that would initiate this beautiful baroreceptor reflex that we learned about when we were talking about mean arterial blood pressure. It would shut down all of the sympathetic pathways in the cardiovascular control center. All that sympathetic output would decrease. All the parasympathetic output would increase, and the body would be doing everything it could to try to reduce the volume in the arterial bag back to a normal volume that would have normal blood pressures in it. But if those baroreceptors are not doing that, if in fact they're firing to tell the cardiovascular control center that everything is normal, then the body's not going to induce all of those baroreceptor mediated changes, and you're going to be in a lot of trouble because there's no possible way you can maintain those high pressures for extended periods without doing extensive damage to the heart as it tries to squeeze against that really high afterload for extended periods. And so in this way, baroreceptor adaptation becomes very dangerous, especially for those individuals who go on for prolonged periods without treating their hypertension. And what might some of those consequences be? Well, damage to cerebral blood vessels is one. The cerebral blood vessels are very susceptible to high pressures that cause them to burst. And this can lead to either clotting in some cases, or even worse cases, hemorrhage, as those burst vessels bleed out into the brain. The higher than normal afterload with high blood pressure puts increased load on the heart, increased cardiac load. This then causes the heart to remodel. It can become hypertrophic, and it can try to build out more contractile machinery to help support the force of contraction that it has to meet with each cycle. But as it does that, it becomes very stiff. The more contractile machinery it lays down, the stiffer that heart becomes, and the stiffer, harder it is to fill because it's less compliant during the diastole phase. So you don't get as much blood into the heart during diastole. You don't get that nice stretch that you need for Frank-Starling law and the optimization of the contractile machinery, and therefore you get a very difficult remodeling of the heart over time, where the heart decides it needs to become bigger and floppier to take in more blood, and then this ultimately reduces the wall thickness of the heart and turns it into a giant floppy bag in the end that is predisposed to heart failure. The hypertension for prolonged periods can also contribute to endothelial cell damage, as we discussed, and this increases susceptibility to things like atherosclerosis and just generally causes physiologic imbalances in pressure that can ultimately lead to things like kidney damage that we talked about if it's prolonged and not sort of restored back into normal levels of pressures over time. And the last condition we're going to look at is the opposite condition to hypertension. That's hypotension. And if we remind ourselves that when you stand up very quickly, the blood is drawn down by gravity towards your feet, this condition of orthostatic hypotension could affect any one of us at any given time if we stand up too quickly. What we know from our earlier lectures is that the baroreceptor mechanisms normally kick into place so that within 1 or 2 heartbeats, we can actually restore mean arterial pressures, get blood going back to the brain, and everything is normal. What happens, however, in someone that has normally low blood pressure is that that individual can't restore the mean arterial pressures back in that short 1 or 2 beats, and the lack of oxygen in the brain actually causes them to faint. Now, this fainting is a very important mechanism because being prone, if we remember, opens up all of those valves between our venous bags as the person is lying prone on the ground, and this gives us nice venous return then back towards the heart, which then will wake up the brain and get nice oxygenated blood back into the brain so that the individual usually wakes up from one of these episodes within a few seconds after fainting. Chronic hypotension can be associated with poor nutrition. Certainly salt and water, vitamin B12 are all key critical nutrients that contribute to blood volume and allow proper blood volume restoration for individuals. And so if someone is chronically hypotensive, one might look first at their nutrition, but it can also be a sign of adrenal cortex defects, as are seen in patients with Addison's disease. And in the adrenal cortex defects, these individuals are producing less aldosterone, and therefore their blood volumes are lower, and they have a chronic hypotensive condition. Lastly, if it's an acute onset hypotension, if it's something that's not normally seen in an individual, then you might suspect something like circulatory shock. And this would be an example of this might be where someone got stung by a bee and they were severely allergic. If they were in a very severe accident and had not only witnessed the accident, but maybe even had rapid blood loss, then their whole system could go into circulatory shock, which is basically all the blood vessels opening at once. And you can imagine how this acute hypotensive event would be critically dangerous. If all of your blood vessels opened at once to blood flow, then that blood would be distributed in ways where the critical tissues would not be receiving nearly enough blood. And so this is why when someone is in shock or forms of shock, you want to elevate their feet and get blood flowing back towards the heart as best you can to hopefully help restore them back to a normal physiologic condition. Okay, that takes us through all of the different cardiovascular conditions and diseases that we're going to look at. Hopefully you can relate these back to some of the cardiovascular physiology that we've learned particularly around blood pressure and blood flow through the cardiovascular system. It's been a great pleasure being with all of you this year. I wish you all success on your exams and in the future. So thanks again, be well, and take care.